everyone can just take a big deep breath. The traffic was terrible, I know. So we're all here now and looking forward to a fantastic showcase of research translation from dietitians. We have just some quick housekeeping before we get started. The toilets are actually back outside the auditorium. Follow the pathway to the left of the main entrance to the TRI, and the toilets are back there. If on the unlikely event we have to evacuate, there are 2 exits at the back where you came in. There's also 2 exits on either side of the stage here. There's free Wi-Fi available today. Why am I telling you this when you all have your smartphones? Because this spot here in the auditorium is notorious for people's phones being a bit out of range. We need you to be in range because the People's Choice Award today is going to be voted by you, and so you will need to have access to the internet to put your votes in. So there is Wi-Fi there that's listed on your run sheet. So check your phones now so you don't have to worry about that when it comes. I wanted to welcome a broad audience here today. Not only do we have the wonderful people here in the audience, we have a wide range of people logging in from video conferencing today. We have some important people from RPOC, so Julie Holcomb's team are logging in from town today. We have a range of people across a variety of different hospitals, from Weipa out to Roma down to the Gold Coast. We have the Prince Charles Hospital, Cairns Hospital, Townsville, Roma, Weipa, Darling Downs, Proserpine, Innisfail, Bundaberg, Caboolture, Gold Coast Hospital, North Lakes, as well as Joe Nolan, the Senior Program Manager of Allied Health in South Australia, logging in today. And a number of universities, Bond University, Griffith University, Sunshine Coast University, and the Brighton Rehab Unit and Wesley Hospital. So if all you speakers weren't nervous beforehand, you're nervous now. But we welcome all those people logging in today through video conference. This session's going to be recorded, and so people who haven't been able to make it to this session will be able to see it at a later date. So those who can see my slide up here can see 16 years. So if this is the answer, what is the question? Can anyone tell me what the question might be if the answer is 16 years? Jack Bell from the Prince Charles Hospital.
How long it takes to get something from the bedside to bedside, or to translate research into the real world?
That is correct, but no extra points for Jack today, judges. That is correct, 16 years from scientific discovery being published to patients feeling the effect of that through standard practice. No one would argue that that is too long. So 16 years from a discovery being made here at this beautiful Translation Research Institute building that we're in today. 16 years, that means it's the year 2033 before a patient next door at the PA will feel the effects of that. So that's something we need to address as clinicians and clinician scientists. Now, dietitians participate across the spectrum of health research translation. Dietitians participate in knowledge generation and scientific discovery, and they also participate by delivering evidence-based practice. But often they're not the same dietitians. And so the recognised gap in knowledge translation in the scientific world is also a real effect in the dietetics world. When I started work as a Queensland Health Research Fellow with the Department of Nutrition and Dietetics, that was really part of our brief, was to help address this gap. How do we close the gap between scientific discovery and clinical practice? And we spent many years really trying to think about ways we can do that. And during that time, however, I observed that there were actually clinicians who were doing it. There were clinicians who were just getting on, having a go and trying to translate research into their practice. They weren't doing PhDs and they weren't doing masters. They were actually just doing their everyday job, but trying their best to have a crack at it, try and translate this evidence that they had read into their clinical practice. And that's where the My Translation Rules initiative was really born, from humble beginnings to recognise and showcase those clinicians who were actually giving it a go and translating research faster than what the literature would suggest. And so we started out doing our little projects and doing our best with those projects. But it was pretty clear, pretty quickly, that we needed to invest more in training in implementation science and doing our projects and our change management, our implementation, in a more scientifically robust way. And so the My Translation Rules initiative was really designed to provide clinical dietitians with professional development in critical appraisal and research translation skills, and to encourage clinical staff to identify existing evidence and translate it into a clinical application within the healthcare sector. So we asked staff to identify and address a clinical problem that's real to them, use some scientific rigour to critique the evidence that's in the literature, design an implementation and carry that out, and then measure some outcomes. And so this award process is really a 500-word application, short, sharp application to address those 4 criteria, and then a 5-minute pitch, which you're going to see today. So the development of this professional development component of MTR was really training and capacity building through partnerships and collaboration. So we partnered with Sonia Osborne, who's here today from OSHI, as well as other research fellows in town, Adrian Young and Shelley Wilkinson and Barbara Vandermeij from the Mater. And with the support of other hospital services, the BDHP and TRI, we were able to design an accessible research translation education package pitched for the professional development needs of the non-researcher clinicians. So TRI and BDHP were really supportive in this and allowed us to, and they hosted the webinar content for the professional development series. And previous award winners presented their case studies as part of the webinar professional development. So from little things, big things grow. Here we are today. We have 10 Brisbane Metropolitan Hospitals who have participated in this MTR professional development series. We've had more than 430 webinar content views. We have video conference people speaking over me. We have evaluated this and it looks like we're doing well. So it looks like that people have increased knowledge, increased skills and confidence with research translation and choosing outcome measures. And we also have 10 showcase presentations today across a range of hospitals from the PA, the Royal, the Mater, the Prince Charles Hospital and Children's Health. So let me introduce our judges. Sorry, wrong judges. We have better judges than that. We have 3 expert judges here today who have volunteered their time to participate in this initiative by reading the applications and being here today. So it's Dr. Sonia Osborne, who was here with us last year and has come back again for the fun, who is a research fellow with the Australian Centre for Health Services Innovation, or OSHI. We have Dr. Kate Kynock from the Mater, Director of Evidence in Practice Unit from the Mater Hospital, and Dr. Sally Eames, from the who is a Clinical Evidence Development Officer at CIS over at the north side. So there is further information on the biographies of these 3 amazing women who are working in doing incredible things in this implementation space, and their bios are on your running sheet for you to read through. We also have some sponsors and supporters to thank before we get going today. OSHI has been incredibly supportive of this initiative through the development of the webinar content and also supporting the first prize today, which is access to 12 months of OSHI's research translation courses through the year next year, a significant prize worth many thousands of dollars. We also have the DNSC who've supported us to put this event on today, Marie Ferguson from Dietitian Connection, The TRI, who support us with resources and the expertise of Carla, their media and comms person, and also Jan Hill from Department of Nutrition and Dietetics at the PA Hospital. So we will get started on our talks. We'll go back to this. This is going to be how you vote for your people's choice, but you don't need this right now. We will bring that up later, and so as you're watching the talks, think about what your favourite is, and that will be the People's Choice Award. So we'll get started. Jack Bell is first. So you come up, Jack, and I'll get your slides done. Now, the way that it's going to work is 5 minutes. Rhiannon is our timekeeper. She will be putting up a warning sign at 1 minute. If you're going over time, I will be sneaking up beside you, which means you need to stop. And we will open up for questions from the floor and also from the video conference connections for questions. So we'll start with Jack. So welcome, Jack. Jack is going to present today on low tube feeding rates in hip fracture, an epic implementation failure or best practice. Thanks, Jack.
Thanks for the opportunity to speak today. So a quick Google search or Blind Freddy would be able to see that pretty much if your patient's starving, if they're malnourished, and if they've just had surgery, you probably should consider enteral feeding. However, in hip fracture, there's a Cochrane review that says that unless your patients are actually severely malnourished, you probably should save enteral feeding for trials. Now, this is a bit of a problem because in the area where I work, more than 1 in 2 hip fracture patients are actually malnourished with significant consequences. 1 in 2 hip fracture inpatients have poor oral intake, and less than 1 in 50, despite this, get tube fed. So, is this a case of lost in translation, or is it best practice? I'm looking for my boss because I think she's the only one who can interpret that, but it pretty much says I'm going to have a beer after this. So, if you look at the consolidated framework for implementation research, adaptation to fit might be helpful to translate enteral feeding guidelines into the real world if we can give consideration to the intervention itself, the patients and the individual caregivers, the hip fracture unit where I work and the local hospital setting, the broader healthcare climate and the actual implementation process that we'd be doing. So that maybe we didn't pay attention to those things. Maybe we're pushing the wrong buttons. Should we be looking at domains around capability, motivation or opportunity for enteral tube feeding in this patient group? Or maybe the behaviour doesn't even need changing at all. Maybe they just shouldn't actually get tubes. Maybe the Cochrane review is right. Possibly there might be unknown unknowns, as Donald Rumsfeld said, which are the things that are impacting translation of the evidence into practice that we don't even know about. And really the only way to find them is probably to do multiple action research cycles to discover and address these. So what we did was we took something for a spin. Paddy King, who's a student from UQ, did this little study. It was a beauty. I wouldn't ever want it. Patient and carer perceptions towards enteral tube feeding in hip fracture. There's the KTIS models that were applied as part of this. But our aim was to find out what hip fracture patients and carers really thought about tube feeding. The setting was my local hip fracture unit where I work, and we purposefully sampled 21 post-surgery hip fracture inpatients and their caregivers. And we did individual semi-structured interviews with inductive thematic analysis. Now the heuristic, which is just a funky diagram that mostly covers what we think happened, if you look in the middle, there's when people might accept the tube. But there's a number of themes that would impact on that, including patient refusal, the necessity of the tube, and knowledge and understanding. And there's a number of drivers there that you can see that can push in and out where those 3 main themes work, which is quite a nice little heuristic considering this was an honours level student. Clearly there was a lot of hard work that went behind that, which I'm not going to go into. But in conclusions, this study showed that an overwhelming majority of inpatient participants did not wish to be tube fed. And further, that there is an urgent need for processes to support shared multidisciplinary team decision-making and better informed consent processes. So that spun us into our next action research cycle, which was performed by A. Sumon, who is a geriatric advanced trainee. And that's looking at developing an enteral tube decision support tool to actually help facilitate this process. And it was basically founded in pragmatic action research and the knowledge to action framework, with the aim to look at whether or not we can develop a tool to assist multidisciplinary team decision support making to work out who should actually be offered the tube. This was a modified Delphi across purposefully sampled multidisciplinary hip fractures across the Australia and New Zealand Hip Fracture Registry. So the results were, you can't see that little graph up the top, but if you use your imagination, the right-hand side shows that we actually got really good consensus by the end of the third round for this particular tool. It actually made a finalist oral presentation at the ANZ Society of Geriatric Medicine. Publication, again, like the last one, is under review for a Q1 journal, and we've got great buy-in for multi-site implementation and evaluation across Australia and New Zealand. So in the end, translating enteral feeding guidelines in hip fracture, is it an epic failure or is it best practice? We don't really know yet, the jury's still out. The cycles to date have shown a lot of individuals don't want to be tube fed, some's informed consent, some's not so informed. Clinicians don't want to be backed into a corner by a protocol, but a decision-making tool might help clinicians work with patients to identify what is in their best interests. So next up, we're going to do a single-site pilot of the decision tool. We're then going to do a stepped wedge RCT across ANZ hip fracture sites. But in the meantime, we still don't exactly know what to do, but if the rules aren't clear just yet, consider, for the patient, that they're translation rules. Cheers. That's me done.
Excellent work. Very good, Jack. Even finishing on your own alarm. Well done. Can I open it up to questions for Jack? Oh, yes. Margie from here. Now, roving mic, so please ask your question. Yep, for the recording purposes. Sorry, is that on, Margie? I don't think your mic's on. Okay, speak into it more. Yep.
I think it's got a flat battery. I can interpret just...
Is that right? Yeah, that is. Thank you so much.
So the question was, is there a single biggest reason for why these malnourished older patients don't actually want to be tube fed? Now, it comes back to those three main overriding themes. One of it is that actually quite a few of them genuinely don't want it with an informed consent decision. Others actually think they don't want it, but they haven't actually had enough opportunity to think about the real reasons behind that. So I would call that lack of informed consent. And then the third reason is really around those drivers surrounding the multidisciplinary team and perhaps some biases that sit in there as well that need addressing. And so that's why the decision support tool is so helpful, because it covers from clinical consensus across Australia and New Zealand 8 key things that clinicians should consider that will actually help to identify or articulate what those drivers should be for that individual patient. But it's not a protocol, or it's not something that backs the clinician into a corner. For example, if the patient has severe dementia, most people would say then that they shouldn't get tube fed. But if that person has dementia, and if they're the brawn, and if they're still living at home with the brains trust, and that's a good symbiotic relationship, then perhaps tube feeding is appropriate. So that's why you can't have a protocol, but you can have a list of X's that you can put on the box down that tool, and then stand back and subjectively make an overall assessment as to whether or not it's appropriate to consider offering an informed consent discussion with that patient. Does that answer your question okay? Yeah, sure. Exemplar quote's a classic. The title is, I would never want it. A lot of people actually genuinely say, look, I'm 90, I've had a good wicket, it's really important that people who have had a stroke and are younger than me get a tube, but really, you know, if this is my way out, that's fine, I'm happy with that, I've had a good life. But that's not everybody, and we can't just lean on that. So I'm very careful not to say that's the reason, because there are lots of different reasons, and we need to be able to articulate those for each individual.
Yes, Marilyn. Please just wait for the microphones coming to you. It's just for the recording, Marilyn. I know you can speak loudly, but we want to record it.
So why is nutrition care optional? I mean, I take the point, I don't want to tube either, and I understand why people don't want to tube in their nose. But why do we make nutritional care more optional than every other kind of medical care?
Yeah, sure. And this is a very interesting point because a lot of the hip fracture surgery we do now is actually for pain relief. So some would even go so far as for some to call it a palliative intervention because I sit there and go, we've done surgical intervention, we've taken all the trouble to give these people surgery, therefore we owe it to them to actually make sure we support them at least through that short post-surgical term. There's a lot of consent issues that surround that we need to get better as teams is actually identifying that because there is some confusion in there and some of it's misinformation on behalf of the multidisciplinary team. So I think we can do a lot better than 2%, but 100% is too far. So I think it comes down to good informed consent, and at the moment we're not doing that very well.
Thanks very much. Well done, Ben. Oops. So our next presenter is Alyssa Hughes, presenting on behalf of the MARTA team. And her presentation is Dieting, It's Not a Piece of Cake, Implementing an Evidence-Based Weight Management Model of Care. Welcome, Alyssa. Thank you.
The inspiration for this project came from new weight management evidence and from a clinical need. In addition to the recent release of overweight and obesity guidelines, we viewed a webinar by Professor Claire Collins who explored tailoring weight management to a patient's characteristics. Additionally, our MARTA outpatient clinics were being overwhelmed with low acuity patients. The aim of this project was to assess, develop, implement and evaluate an evidence-based model of care for weight management at MARTA Group. A systematic review of best practice recommendations for weight management was conducted and drew evidence from DAA and NHMRC guidelines. For adults who are overweight or obese, it is recommended that lifestyle change, including a reduction in total energy intake, increased physical activity and measures to support behaviour change be implemented for successful weight management. This is further supported by Professor Claire Collins. From Claire Collins' work, we know that weight management patients can be categorised into 1 of 4 kilojoule restriction groups based on their patient-defining characteristics, including previous weight loss attempts, previous dieting attempts, weight loss, nutrition knowledge and dieting history. The groups include the Australian Dietary Guidelines, Reduced Energy Diet, Low Energy Diet and Very Low Energy Diet. Today I will cover how we collected baseline data about our service, then operationalised the evidence into a usable, practical, systematic approach to meet service gaps. We then measured and re-evaluated our adherence to the guidelines and the effect on our services, with key learnings and reflections at the end. For 3 months, we collected baseline data for all patients whose primary nutrition intervention was weight management, with follow-up of these patients where possible. As well as service flow data, we collected data that allowed us to determine the adherence to the guidelines. This included anthropometry, review frequency, and what dietary interventions were provided. The data was collected and entered into this database at the end of each month. A flowchart was constructed to ensure a systematic, guided application of the evidence, including patient defining characteristics mentioned earlier. Closer to implementation, it was identified that further decisions needed to be made due to clinic capacity to ensure patients receive a timely review. Serendipitously, the following paper was published highlighting a lack of engagement and awareness of a government-delivered telephone service called Get Healthy. Get Healthy participants received 10 free phone calls over a 6-month period with a dietitian or exercise physiologist and is shown to have a mean average weight loss of 3.6 kilos while also improving diet quality and exercise. Introducing Flowchart 2.0, incorporating department processes. The flowchart still categorises patients into 1 of 4 kilojoule restriction groups based on their patient-defining characteristics as per Claire Collins' work. But we prioritise seeing patients 2 weeks pre-surgery and those referred on from OPSC due to dedicated funding. All other patients were triaged to the MARTA outpatient clinic and offered to be linked into Get Healthy. The process was built into a clinic time slot once a month. Flowchart 2.0 was then presented, distributed and implemented into the department, and 4 diet sheets were developed for ease of systematic delivery of the recommendations. They include the Australian Dietary Guidelines, Reduced Energy Diet, low energy diet, and very low energy diet, which I can go through at a later time. We learnt from previous data collection methods the importance of analysing not only what we collect, but how we collect them, and as a result developed a collection form to be completed after each patient and formatted for ease of data entry. In the pre-phase, only 70% of patients that were referred to the clinic were seen, with losses due to DNA and cancellation. In the post-phase, over half were able to be referred out to get healthy with excellent uptake. The rest were triaged according to the flowchart with 100% attendance. Upon review, we identified that 5 patients could have also been referred to get healthy. Compared with pre, we have significantly greater guideline adherence to the review recommendations, including fortnightly follow-ups. Compared with the pre-phase, our interventions in the post align with guideline recommendations of lifestyle change, energy deficits tailored to the individuals, and supported by behaviour change as a result of our resources. There were 3 times as many patients in the pre-phase, with similar weights and diet quality, but greater waist circumference and BMI in the post. This might be a function, sample size, or acuity, something we will explore once all data has been collected. There are 13 patients still to use. For their 3-monthly follow-up, we have seen 3 patients and have had 6 patients' DNA. However, we obtained weight data on the phone and are awaiting them to post back the diet quality surveys. Key learnings to date include stakeholder involvement, ensuring well-rounded clinical model with research rigour. However, ongoing revision within the department often highlights further process improvements. Data collection was easier after each patient, but still requires prompting. We will continue to revisit data collection and triaging processes until the end. Thank you to all dietitians involved.
Excellent. Take a deep breath. Great paper, by the way. And perhaps we should have an award next year for those who have translated the most local research into practice. Fantastic work. So no extra points this year, but perhaps for next year. So we've got time for one question. We're going to open it up to the video conference people first. Ree is just going to unmute. Is there anyone from video conference that would like to ask a question? No? Okay, so we'll open it up to the... Yes, Adrienne. Sorry, can we just use the microphone? Thanks.
That was a really nice presentation. It sounds like the main group of people that you needed to change in terms of the behaviour or the service was the dietitians, and I wondered if there were any barriers that you anticipated or that you assessed, and what strategies you needed to do to overcome those to get the outcomes that you saw?
Yeah, the main barrier that we kind of identified was time. So we were finding that there weren't a lot of time. It was a collaborative approach, and a few of the dietitians are in the audience if anyone else wanted to chime in with it, but it was time. So as I mentioned, we had to then review to identify that clinic capacity couldn't hold all the patients that were being referred through. And we're constantly reviewing and going back and reflecting on the work. We have fortnightly meetings to ensure that everything is still, and we did that up to date.
Okay, great. Well done. Congratulations.
Thank you.
Moving on to the next presenter, Hannah McKay. Okay, welcome Hannah, who's also representing the MARTA group, presenting today on establishing an evidence-based dietetic service in haemodialysis.
Thank you, and also I wanted to acknowledge Katrina Campbell for her help in mentoring throughout the process. So mid-2016 there was news that a new dialysis service was opening at MARTA Brisbane with the external provider of Fresenius. Given this great opportunity to do everything from scratch, apart from the initial question of where do I start, there was then the clinical question of how can we make sure that this practice is truly evidence-based. So first of all, there was a review of literature, so looking at the various nutrition guidelines for kidney disease, so including the Kerry, Kudoki, the various working group parties from Australia, New Zealand, also the UK. These documents, along with other key articles, I summarised into a document of best practice or a BPI. So this BPI outlined the various aspects of the nutrition care process, but also assisted in showing the outcome measures that we'd continue to monitor. So those were that all dialysis patients should be seen at least every 6 months for a full assessment, including with a validated tool with PGSGA or SGA. Also that all new dialysis patients should be seen within 1 month of starting dialysis. And there was also recommendations for the workforce, so FT of 1 to 100 patients. Looking a bit further into the literature was then determining the malnutrition prevalence for this population. So this varies quite a bit. However, literature shows it's up to 64%, whereas other research that showed implementation of this best practice guidelines, there was a malnutrition prevalence of less than 5%. So that became our benchmark at MARTA. The implementation phase, so after I did the BPI and also looking at determining those outcome measures, there was a lot of collaboration with different partners. So not only the external provider Fresenius, but also other dialysis sites, thank you to the PA, the local nephrologists, nurse unit managers, and also MARTA education. So that then leads on to the next part where we developed a training package for staff, so translating that research into training packages and delivering it in 10 face-to-face workshops with nursing staff, nurse unit managers. This was then made available online for later starting staff. Also, it was then adapted and a training package for the MARTA dietitians. Once the unit opened, there was then that translation of research into local policy and procedure and development of a work area resource. So that allowed for continuity between different covering staff for the unit. We developed a database to allow for scheduling of patients and monitoring of those outcome measures that were time related. And also statistics were kept for and ongoing for dietetic time. Continuing on, there's ongoing collaboration in the multidisciplinary team. I attend the monthly blood reviews with nephrologists, the pharmacist and nursing staff to allow for quick and effective communication, determining prioritisation of patients and a timely proactive service. There's also that continued monitoring and evaluation of outcomes, so that database is in day-to-day procedures, and then reporting 6 monthly back to key stakeholders, including locally and also the Renal Queensland, the interest group. There's ongoing education for myself and also for the staff, so I present at the nursing staff in their education calendars and also with the patient newsletter as well. What that meant in terms of outcomes for our service, so the initial 6 months, all dialysis patients were seen, so there was 26 patients that started or in that initial 6 months. All except 2 were seen within the first 1 month if they started at the MARTA. Those 2 were delayed due to workload over Christmas and New Year's. Malnutrition prevalence, so remembering that literature showed up to 64%, our initial 6 months was 7.7%, so slightly above that benchmark, however was representative of only 2 patients, so given that was a small sample size, hopefully as that continues to increase, we'll be able to be more in line with that benchmarking. In terms of the time allocation, so again slightly extra than the recommended for workforce, although that did include that time for service development. It was also a good time to see when there was the release of the FEEDS document that we were able to show consistency with those statewide recommendations. So in conclusion, we have been able to translate research into practice with establishment of an evidence-based service. Doesn't mean there isn't need for ongoing monitoring, but that's embedded into day-to-day practice. Hopefully will lead on to further research and collaboration, so hopefully assisting with any other sites, and also continuing to show that that evidence-based service does have that benefit for malnutrition prevalence. So we know that that reduced malnutrition prevalence has benefits for different risk factors, including reduced mortality risk for our patients. Thank you.
Excellent, well done. Can we open it up to the floor for some questions? Up the back, if we can get the microphone up to Kylie Boyce from PA, up the back there.
Hi Hannah, thanks for that presentation, it was really good. I just have a question. You said that the research showed that malnutrition's up to 64% in this population. What made you decide on a target of 5%?
Yeah, the 5% was from other research that had been done that was assessing when there was implementation of best practice guidelines in other hospitals, so another haemodialysis site, that was their malnutrition prevalence. Obviously that's going to vary a lot, and there will be that comparison to the statewide prevalence rates that we do as well.
We have a question down here with Jack.
Yeah, great presentation. So I guess, although you started the unit, I'm assuming the patients weren't you, so they've come from somewhere else as drop-ins.
They varied.
Okay, so I guess my question is, were you able to capture baseline data on those on coming in for nutrition status across a number of metrics so that then you can show that improvement over time?
Yeah, I guess there was handover from different sites, but given that they came from different units, there is variation in terms of the time frame that they'd done their sort of 6-monthly assessment in. This was more just the initial 6 months, and that's obviously going to be ongoing to show that we can maintain those lower prevalence rates ongoing as well. So it's half baseline, but really, yeah, it's more just in that initial 6 months of our service.
Here from Simone from the PA. Okay, just repeat the question.
Yeah, that has been something.
Sorry, can we just repeat the question from Simone? If you want to just repeat it.
Yeah, so Simone was just saying that there was a lower malnutrition prevalence for the statewide data, and it was whether or not there was any other factors that I might be looking at for monitoring. That is a good question, because there are obviously with this population a huge amount of things that we can look at in terms of monitoring, and also we know that there is that sort of shift as well in terms of the overweight and obesity of this population, again biochemistry, control, that type of thing. There's a huge amount of factors, and it is something I've considered. I guess that there was that decision made upon the starting of the service that there is that link to malnutrition that we know, and that process hopefully will indicate the numbers with the malnutrition prevalence, but it is something I've kept in mind for the database to be looked at retrospectively as well if we're wanting to sort of pinpoint different data factors for later analysis.
Great, thanks Hannah. Yeah, it raises a really important point about thinking about what your outcome measures will be rather than your traditional ones that we rely on. Really excellent work. Our next speaker is Ayala Rogani from the Queensland Paediatric Overweight and Obesity Service Development, presenting today about their journey to creating an integrated centre of excellence. Let me get you started. There we go.
Thank you. Hi, everyone. You can hear I've got an accent, and when I get nervous, my accent gets a bit heavier, so bear with me. Hopefully it will be okay. So we all know, also from the talk from before, that obesity is a significant health problem, and 1 in 4 Queensland children are either overweight and obese, and that means that's 217,000 kids. 158,000 of them are overweight, 59,000 of them are obese. And obviously we're concerned about it not only because maybe later in life, in adulthood, they develop other health conditions, but we already see quite severe comorbidity with that as well at that age. Okay, so there is quite a lot of evidence about that lifestyle intervention and supporting environment for prevention and management of pediatric overweight and obesity. And as it was mentioned before, clinical practice guidelines have been published as well. However, despite all of that, the majority of one-off programs aimed at prevention or managing pediatric overweight and obesity have universally failed. And because there is a lack of integration of the programs within the healthcare system and a lack of consistency in how to actually address the problem in a real-world setting. And I guess an appropriate framework, we felt that an appropriate framework or model of care that takes a system approach using evidence-based practice and clinical tool needs to be developed, and while still allowing for flexibility required to individualize the program and continue making it family-based program as well. So the collaboration. So in order to address this, we collaborated together with the Queensland Child and Youth Clinical Network that sits under the Department of Health, University of Queensland, which are research partners, and also Preventive Health Branch. I guess one of the issues that from my personal experience working in hospital, you do things in isolation, and it was very important to do things in a partnership, and also very important to include the prevention part of it. And yeah, so we were looking at the whole aspects of the system, not just the treatment, but actually looking from prevention to the treatment. So the plan, so the concept to develop with the partners to understand the significance of the problem and brainstorm potential solution. We reformed the Pediatric Obesity Working Group, which is a working group that incorporates most of the HHSs from Queensland, PHNs, universities as well, and a variety of clinicians did as well. And we have developed a framework based on the evidence that we found. The other very important aspect of it is obviously the research aspect of that. And as we are, I guess, developing our services, we are evaluating and make sure that we're changing according to what we find as well. So the outcomes, we've got these two, hopefully not too Queensland Health looking documents that hopefully will be available soon online, and will also in a hard copy as well. It's two documents, an overview document, which outline the system-wide integrated approach for tackling childhood overweight and obesity in Queensland, and a model of care. It's a how-to guide. So basically, it incorporates prevention, early intervention, primary healthcare, secondary healthcare, tertiary healthcare, and beyond that as well. Detail the expected who can provide the service and how they can provide it, and then resources to support them to help that. And in the future, we were looking at obviously have a communication plan and implementation plan, so we can help services implement it. So again, not talking just about HHSs, also talking about GPs. We're looking at education to GPs and primary health providers, so we can help them, I guess, address the issue, identify the issue and address it quickly. And one of the outcomes of our research, for example, found that our referral pathways are not so good. Basically, all the kids have been referred mostly they've already been involved with the healthcare system, so with a pediatrician, rather than being identified early and the issues being addressed earlier on before it becomes more severe. That's it.
Whoops, well done. You did very well with your accent. I know what it's like. My Ocker Aussie regional Queensland accent comes out by the end of sessions like this too, so I can relate. So we're going to open it up to questions. We'll go to the video conference groups first. Is there anyone on video conference that would like to ask a question? No? Okay. As you will learn, you need to get in quick video conferences. If you have a question, be ready to go when I offer it. So let's open it up to the audience. Who has a question here for Ayala? Up the back. Amy Davis, up the back there.
Thank you for the presentation. I just wondered, in looking at the literature in terms of models of care, so being able to provide a service statewide, if you identified any particular models of care that were a cut above the rest?
I think there's evidence there really. So last year in America, they published really comprehensive guidelines, including contact of hours that they recommend that have the best outcome. It's quite high intensity. So they recommend 6 to 12 months and quite regular contact. We do acknowledge that that's sometimes hard for service to deliver, but we kind of encourage people to still deliver whatever they can. But definitely seeing, similar to what the adults find, definitely intensity should be fairly high initially in order to, get results. From that point of view, talking from the treatment point of view, the other end of the system point of view from prevention and early intervention, it's actually to measure the weight and the height of the child and actually raise the problem when a GP identified the problem, and not just, I think most people, including dietitians, have problem actually raising the issues with the family in a way that's respectable and in a way that actually the family is going to engage and start the journey with them. So.
And also, can I just quickly ask, in terms of your service model, like, does your service provide ongoing support sort of in any way to people who are implementing those guidelines?
You mean statewide?
Yeah.
So that's what we are planning. So the next step is obviously to communicate the outcome of this to everyone and then to help services to implement that. So one way that we're going to support, for example, GP and primary health providers is we're going to start education series. I don't know if people have heard about ECHO, which is basically a telehealth way of providing education to people anywhere in the world. And we're going to start doing that pediatric obesity in term 1 next year. And we're hoping to run education session with each term, each year, to be able to, I guess, provide that education. The target there will be the primary health providers. Thank you.
Well done. Now, I meant to say before we started that the order of speakers was random, so we did literally pick names out of a hat for the order of people. And Carrie-Anne Lewis is here. There's the first representative from the Royal Brisbane and Women's Hospital presenting on her team's pilot implementation of a 7-day nutrition action care plan. Thanks, Carrie-Anne.
Hi everyone, thanks for letting me present today on my project. So what was our clinical problem? As we know, there is good evidence of how to prevent and manage malnutrition in the inpatient setting. However, systems to embed these strategies into practice are yet to be evaluated. In 2014 at the Royal Brisbane, we implemented a dietetic assistant, or I'm going to use the term DA, delegation model of care for screening and escalating patients' nutrition support. However, there was no communication of this care implemented alongside this in 2004 in either the medical record or to the multidisciplinary team. Also, regular audits at the hospital demonstrate that nutrition support continues to be suboptimal. So in 2016, our aim that we put together was to develop and evaluate a system for the DAs to implement and communicate appropriate actions to optimise the intake of our at-risk patients. And here we use the Knowledge to Action framework to guide this project. So what did we do? We adapted our knowledge to the local context, and over a 6-month period we engaged with key stakeholders and worked with our DAs to develop a system that met our aim. Here, barriers were identified and addressed on an ongoing basis. So what is the SNAC tool? So SNAC is a tool that documents nutrition care plans, nutrition intake and nutrition escalation by dietetic assistants. This tool lives in the end of bed chart and is a part of the medical record with the aim to improve the communication and documentation with the multidisciplinary team. The flowchart, which you can see on your screen, describes evidence-based systematic processes for DAs to lead escalation of nutrition care, which guides the SNAC tool document. The flowchart itself is not new and was based off the 2014 implemented processes. Therefore, most of the current processes were already expected of the DAs within their workload, with the exception of a more systematic process for DAs to assess intake, and you can see here on the screen that's how we developed the swing tags, where they could decide if a patient's intake was 100, 75 or 50%. The documentation in the bed chart and filing in a clinical note was also a new system for the DAs. So this is the tool here. The table columns are to be filled in daily by the DAs for 7 days, with the columns for the patient's current nutrition care plan, their intake, any barriers to intake, and the action taken by the DA, which corresponds to the flowchart, and then a signature section for accountability and documentation. And this tool is then scannable to IMR, which is our electronic medical record. We then piloted the implementation of SNAC on one acute hospital ward with the aims to identify barriers and enablers to implementing SNAC and identifying numbers of patients meeting criteria, and these are the outcomes I'll present today. So our implementation phase was heavily education focused. So 80% of our DAs were involved in the development of the tool. However, it was still an expectation that all DAs went to one education session on SNAC implementation before we piloted it. And then we had one session with the DAs and dietitians together. And then we also educated ward staff and the multidisciplinary team. We then implemented for a month. We implemented evaluation concurrently, and we developed a staff feedback service based on the Combi model, which Jack commented on earlier, for behaviour change, which looks at capability, opportunity and motivation for behaviour change. There was also a weekly DA dietitian meal audit, which allowed the dietitian to look at numbers of patients meeting criteria as well, and also to allow for modelling. And then we audited completed SNAC tools. So what did we find? So despite taking a structured approach to implementation, evaluation demonstrates poor completion of the SNAC tool by the DAs. On average, 5 patients a day were incorrectly not identified for the SNAC pathway, and there was poor completion of some sections of the tool. For example, the action section, which is what we were really interested in, was completed 34% of the time. Where were our barriers that we identified? So when we look at capability, there was inappropriate nutrition support actions based on intake monitoring, which suggests there's a barrier related to skills and knowledge around these tasks. When we look at opportunity, the primary barrier identified by the DAs was time within their existing workload to complete this new task, and also poor availability of bed charts. When we look at motivation, there was a perceived lack of value, with only 30% of DAs reporting SNAC as valuable. So where to from here? We are going back to the DAs. We are going to reassess through semi-structured interviews, so getting a bit more information from them, the dietitians, and also the patients, the most important people. We're also reviewing the DA's work schedule with regards to their clinical time, and we will then refine this to re-implement SNAC. Thank you.
Well done, Carrie-Anne. Questions from the audience? Jack.
Has there been any consideration in terms of making it a bit more interdisciplinary at all?
Yes, definitely. When we first developed it, we approached the nurses to see if it could be a tool that the team could use, because obviously the nurses are the other key team members involved in nutrition care. However, they're feeling very form-maxed out at the moment. So we implemented it with it being a DA tool primarily for the DAs, but we invited any other team member to use and document on the tool. So it wasn't DAs only, the rest of the ward was able to communicate with that tool. And anecdotally, because it was my ward and I implemented it, the nurses and doctors loved it. They embraced it, they brought it up in my team meetings, they want it. It's just a matter of refining our little hiccups.
Well, just one quick question. Shelley, it's a great example, though, of projects that don't go as planned.
Yes.
And also a good reminder for everyone in the audience who might be thinking of, things that they've done in the past but wouldn't want to present it because it didn't go as planned. You can see how much learning you can get from seeing things that don't go as expected. Shelley, quick question.
I guess it was just if you could reflect on how you implemented it in the first place, knowing what you know now, what would you have done differently?
Yeah, so that's a really good question. And it probably would have been to do this step 1 on our future planning from the start. We did collect that data with the surveys from the DAs using the Combi model, but it probably wasn't enough information. And doing the semi-structured interviews to really tease out why we're getting those barriers would have been best to do at the start. Yeah.
Excellent. We're halfway through, folks. Halfway through. Time flies when you're having fun. Taylor Robinson from the PA, the first representative from the PA hospital, is here. And Taylor's going to present on her project on early oral feeding in post-operative colorectal patients. Welcome, Taylor.
Hi, everyone. All right. So it's traditional practice to keep patients nil by mouth until intestinal motility returns following surgery. Thereafter continues a slow progression from clear fluids to a normal diet. But do we really need this delay in diet upgrades? Early oral feeding in colorectal patients is associated with a significant reduction in postoperative complications, infections, length of stay and mortality. An increasing number of clinical practice guidelines recommend early oral feeding in the form of an unrestricted diet within 24 hours post-operatively. This is supported by high-level evidence, many of which carry a Grade 1A recommendation. And for the purpose of this project, we'll define early oral feeding as a full diet on post-operative day 1. So despite established guidelines, the translation of evidence into practice remains an ongoing challenge. We conducted a baseline audit in June and July 2016 to identify the post-operative day and corresponding diet in elective colorectal patients at the PA. The median time to diet upgrade was post-operative day 1 for free fluids and post-operative day 4 for a full diet. Given the discrepancies between guidelines and current practice, this project aimed to identify barriers for successful implementation of early oral feeding in post-operative elective colorectal patients. Applying the iParish framework, the innovation was clear. Early oral feeding has an established evidence base that offers an advantage over current practice. Engaging our recipients was the next consideration. I needed to understand the opinions of our stakeholders and the value they place on the innovation. And I also needed to understand the context, the ward culture, and how systems on the ward and within the hospital could support the innovation. I conducted 16 semi-structured interviews with our stakeholders. Interviews were recorded, transcribed, and independently analysed by 3 reviewers. And I'm now going to present the 6 key themes that were identified from the interview results, with supporting quotes from staff. So theme 1, there was a broad awareness and strong cultural acceptance of the benefit of early feeding. One consultant said, if it's in those protocols, then it must be safe, and with good evidence supporting it. So I'm a big fan of early oral feeding. Theme 2, decision makers use a pragmatic approach to diet upgrades. And this is usually dependent on the patient's clinical assessment. If you see them day 1 post-op and they're nauseous and vomiting, you don't want to push them too hard. And especially in the elderly population, you don't want them to aspirate. I find one of the most reliable things is when patients actually complain of being hungry and are interested in food. I think that's usually a sign you're probably underfeeding them. Theme 3, disparities exist in diet upgrade practices. Diet upgrades are variable and often depend on the individual's training and education, and the speed of diet upgrades vary between individuals. I'm sure the guys who are very reluctant to start oral feeding too early is just because that was the way they were taught and they haven't had any issues with it. So why would they change? People tend to go straight to clear fluids and then sort of stepwise up. So clear fluids, free fluids, diet is tolerated. My post-operative notes say they can start free fluids when they're awake and alert, and I upgrade to normal diet the next day. Theme 4. There is a limited understanding of the nature and availability of different hospital diets. They're confusing, and they have a different name for the same diet a lot of the time around various hospitals. And there was no clear consensus on the rationale for using these different diets. I don't know whether there's just a bit of hocus pocus or whether there's any real difference in giving someone clear fluids or free fluids. I prefer to stay on a light diet for the first week or so, rather than T-bone steak. I don't think that's appropriate. Theme 5, diet upgrades are not systematically tracked and vulnerable to communication breakdown. It's all very well for you to see the patient and make a decision, but then that has to be communicated to nursing staff who have to understand it, not be on a break, and then they might forget or the message gets changed. They don't really track diet upgrades, you just follow the notes, and things do get missed because the last note said, Red said this, and then they meant to say upgrade, but they haven't. And theme 6, an elective surgery early oral feeding pathway with facility to opt out for complicated cases was widely accepted. Interview outcomes identify 4 potential barriers to early oral feeding, including a need to address stakeholder understanding of hospital diet upgrades. These results indicate that implementing systems-based approaches to track diet upgrades that include feedback to stakeholders may reduce disparities in practice and improve time to diet upgrade. So where to from here? The next step is to communicate the results back to stakeholders within the colorectal team. We'll address any of the barriers identified and, with their support, design and implement an early oral feeding pathway within the hospital complex context. And just a few acknowledgements. Thank you.
Well done, Taylor. We're going to open up the questions to the VC participants again. So VC people, you are off mute. If there are any questions for Taylor. No questions? Okay, open up to the audience. So we've got two. We'll start up the back here.
Hi, that was excellent. Thank you for that. I'm just wondering if you consider the ERAS pathway. That's a very well recognised across the globe, but particularly so in colorectal patients.
So that's a very good question, and it's something that we are working on at the moment. I suppose for the purpose of this project, I was just focusing on early oral feeding, which has quite good standalone evidence independent of ERAS, and something that I felt like was achievable in the scope of dietetics without too much multidisciplinary input. But in saying that, we are moving forward hopefully with a bit more of a formalised ERAS protocol within colorectal at the PA, which this will nicely then fit into. Yeah.
Shelley?
I thought that was a great presentation. I thought it was fascinating because often we bitch and moan about the nurses and the doctors not following our instructions. Why are they doing this? But yes, just to hear their perspective was fascinating. And you might have said at the beginning that I might have missed it. But has anyone else actually asked them why they do what they do? Or what they believe about these diets?
Not that I'd really come across, unless there's something out there that someone else can add to that. Yeah.
So you're saying it's nice to be asked? Yeah, it is. Excellent. Thank you very much, Taylor.
Thanks.
Okay, welcome our next speaker, Claire Crease, who's Senior Metabolic and Medical Dietitian from the MARTA Group, presenting today on her project Ensuring Optimal Nutritional Management for Adult Inpatients with Inborn Errors of Metabolism. Thank you, Claire.
Imagine living on a strict low-protein diet where your daily allowance of protein is only 10 grams, the equivalent of 2 slices of cheese. Non-compliance might trigger some serious health outcomes. Imagine having blood tests every month. Imagine drinking foul-tasting amino acid formula 3 times a day. Now you've got a fever and your clinic nurse tells you go straight to the emergency department. Imagine having to explain your condition to the doctors because they've never heard of it and they don't know how to treat you. You're nauseous, dizzy, and you start to slur your words. Finally, a meal arrives, but it's a chicken pasta. You know you should be on your low-protein diet, but this is a hospital, right? They would never give you something you can't have, right? You eat your meal, and straight away you start to feel faint and your nausea worsens. You know something has gone seriously wrong. Inborn errors of metabolism are a group of rare genetic diseases caused by the defect in a function of enzyme involved in metabolism. Treatment requires lifelong medical nutrition therapy and daily formulas. Immediate access to high-energy foods and specialised formula is monumental to recovery for these fragile patients. Inadequate access to metabolic diet therapy and formula can lead to severe consequences such as reduced IQ, organ failure, and even fatality. A new service in 2015 saw an influx of adult metabolic inpatients to MARTA. This in turn led to an increase in food-related clinical incidents for this high-risk group, which could have serious patient safety risks. Initial audits found that 47% of our patients were not being referred to the metabolic dietitian and not being assessed within a timely manner. This led to a best practice investigation which revealed several consensus guidelines, but there was a big catch. They were all for paediatric populations and all low-grade evidence. The rarity of these diseases means that there is insufficient clinical knowledge and awareness globally for the adult population. To complete the best practice investigation and attempt to fill the knowledge gaps, a benchmarking process was undertaken. 7 metabolic centres in Australia and New Zealand responded to the benchmarking survey. Questions about metabolic food service and formula provision referral processes and after-hour metabolic services were discussed. The results from the benchmarking recommended urgent referral to the metabolic team, including an experienced metabolic dietitian within 24 hours of admission, and immediate access to individualised sick day plans for all clinical staff. These recommendations informed the basis of the intervention to ensure optimal nutritional care for these patients. Throughout the intervention journey, the IPARIS framework was used. Importantly, we needed to adapt the recommendations to fit within the MARTA adult framework and context and assess the barriers to this possible intervention. All of these steps were heavily facilitated by the metabolic dietitian. The implementation phase required several steps. Firstly, a redesign of the food service, allowing low-protein metabolic diets within the room service choice-on-demand model. Then, automated referral alerts and sick day plans were updated electronically to all patients, and new formula room processes were developed, allowing 24-hour access to the specialised metabolic formula. Of course, stakeholder consultation continued across the implementation phase, and several in-services and audits took place to measure effectiveness. The outcomes of this were assessed in August this year, showing that 100% of our patients had an electronic referral alert and sick day plans in place. 100% of our metabolic inpatients were admitted to the MARTA were referred to and assessed by the metabolic dietitian within 24 hours, which is a huge improvement from baseline, and 100% of our patients requiring metabolic formula were receiving this, including after hours. The success of this intervention means it will continue with ongoing 3 monthly audits of diet assessment timing, sick day plans, and formula usage. The intervention has already been built into established frameworks, including clinical staff adding alerts for new patients and competency training for our DAs. The process and outcomes of this intervention were shared at the recent International Congress of Inborn Errors of Metabolism in Rio de Janeiro in September this year. Translating this research into practice now ensures all of our inpatients with inborn errors of metabolism receive optimal nutrition, speeding their recovery time and being more in line with best practice. This intervention has the potential to be replicated in other metabolic adult centres worldwide and contributes to the growth of metabolic research with our adult population groups. And this is why my translation rules.
Excellent. Potentially, truly life-saving project there. Can we open it up to questions with the audience? Yes, down here. Wait for the microphone, Simone, from the PA.
Thank you. That was a really interesting presentation. I was just wondering how you go about communicating these sick day plans if one of your patients presented to perhaps another hospital.
Yep.
And maybe if you thought about how the digital hospital might facilitate further rollout of these in the future.
So we, as the metabolic dietitian, I have a copy of all the latest updated sick day plans on my USB and our database at the hospital. The doctors, consultants, fellows and 24-hour on-call doctors also have copies of that on a USB stick that they carry around. So we've always got access to it. It's freely accessible to our ED doctors and ward nursing staff and doctors. So if a patient does come in after hours and they're not sure of what the condition is, they can just see the clinical alert at the bottom of our electronic screen and say, okay, I better read this documentation. So it's very clear and highlighted quite, it's highlighted for each of those particular patients. In terms of that ongoing sustainability, the patients come into clinic face-to-face every 6 months, so we see them on a regular basis to update the sick day plans and change them according to their preferences and what foods they want or the formula that they might have changed prescription of. And then in terms of if the patient's admitted elsewhere, that's where the trouble lies, because often we don't hear about it until after the fact. So in clinic, again, all of the metabolic patients are given clear, strong communication. You must contact the metabolic team before you present to any hospital, or even you must contact the metabolic team as soon as you get sick. So in that scenario early on with our patient having a fever, they contacted the clinic first and the clinic said, yes, you need to go to ED. So that would be the general case for our patients. Of course, sometimes they don't always listen to the recommendations, so they just get sick and present to any hospital, and then that's where the trouble lies. So we're trying to push the education for our patients and filter in as many gaps as we can for that. Thank you.
Okay. So next up we have Paula McDermott, Senior Dietitian from the Royal Brisbane and Women's Hospital, presenting today When Acute and Chronic Illness Collide, Improving Dietetic Referrals for Acute Renal Inpatients. Welcome, Paula.
So who in the room goes into complete panic when they get that referral for a renal inpatient? Anyone? Absolutely. You're not alone, and this is what this is about. We know that our renal disease patients are high risk of both acute and chronic nutritional issues. At the Royal Brisbane and Women's Hospital, the nutritional issues from a chronic point of view are really well addressed in our multi-site, well-established, evidence-based outpatient settings, reviewed 6 monthly. We get great referrals for our MDT meetings. On the other hand, the acute illnesses, such as our MST greater than 2, our pressure injuries, the poor oral intake for a long period of time, and those severe acute kidney injuries are actually rarely referred for inpatient dietetic input. Why? Because of the word renal. Data was collected over a 2-week period, and what you'll see highlighted in red is most of the referrals come through our very valuable renal resource nurse, which is a part of our nephrology team. The referrals coming through from her are mainly healthy weight education, renal diet education, potassium education when they're not established on dialysis, and phosphate binder compliance. So 45% of these were actually appropriate when we collected it, so there's a big gap. So what does the evidence say? We've already seen today, we've got lots of national and international guidelines, the CARI, the KDOQI, American, European, Australian dietetic renal guidelines that covers everything. Nutritional assessment, intervention, monitoring across all stages of kidney disease. The timing, the frequency of when we actually do that in an outpatient and dialysis setting. However, no recommendations to guide or manage the acute inpatient setting. On the other hand, the evidence for managing acute nutritional issues in the general hospital population are really well documented. Malnutrition, pressure injuries, and how is this applicant to this particular inpatient group, and how can we integrate it into guidelines? So I used the COMBI system framework to understand the behaviour around it, and we've seen that from Jack and someone else today as well. So I had a great opportunity. I had a renal resource nurse who was an absolute champion with nutrition and central to the case management around how these patients are managed and how they're referred. The motivation. Dietetics is a valuable member of the nephrology department, so we're always getting referrals from them, and they're keen to engage in anything that supports quality improvement. What we did lack was the capability, or we didn't lack, but what we identified was, with the nursing staff, this really poor understanding of complex interplay between acute and chronic renal issues. Same with the doctors. The doctors had this poor understanding, and they really focused on that chronic renal issues rather than the common risk factors acutely unwell patients have, such as malnutrition and poor oral intake for weeks. The nurses heavily relied on the doctors to actually say, can you get the dietitian to see this? And actually forgot to use all of those tools we use within every system, MST screening, anything, the poor intake tracking. So what did we do? So based on the assessment, the following strategies were actually implemented. So as far as the nutrition education, what we actually did is we used multiple ways of doing it. one-on-one educations, small little group educations with nurses, doctors, dietetic assistants, allied health assistants, and actually give them an idea of what a renal patient actually looks like, and in fact to incorporate other things. The other thing that we worked collaboratively with the renal resource nurse was around a management pathway of renal inpatients to refer to a dietitian, a collaboration of the national and international guidelines of things we may be leading to, plus those guidelines that we also use around malnutrition and pressure injuries. So, has it made a difference? So the evaluation 3 months post the implementation phase, 91% of those referrals were appropriate. The doctors, and in particular the junior doctors, felt more empowered and expressed satisfaction with the increased dietetic input. We were starting to see, but not actually measured, shorter stays for those severe acute kidney injuries in particular. The weakness, 6 months evaluation, we saw a drop in the actual the appropriateness of the referrals, which demonstrates the importance of sustainability and continued engagements. I stepped out of the workload, the renal resource nurse changed as well. So it's that ongoing support with those. There's always an opportunity in everything that we do in dietetics, and certainly looking at decreasing that length of stay, which obviously reduces the cost to the hospital, but more importantly, it's about patient experience and patient-centred care and ensuring that we're addressing that as well. Thank you.
Great job. We've got time for one question. Again, we'll open it up to the VC participants. Is there anyone with a renal question on the VC audience? Oh, we got all excited, but I think they're just making it. Okay, anyone from the audience with a question? We've got time for one quick one.
Anyone?
No? Oh, Kylie Boyce up the back from PA.
Thanks, Kylie.
Armandine's behind you.
Thanks, Paula. Quick question. You mentioned that yourself and the renal nurse moved out of the role. What do you think it would take for it to become sustainable without relying on the individuals?
Absolutely. The processes are all actually in place. So all the, just going on to the education side of things, we worked with different groups as far as making sure that it was sustainable, so putting in an RMO orientation handover book. With the medical staffs, we have an opportunity once a month to actually do presentations, aka things like this. So the actual presentation, so it's actually in our clinical handover. So when there's a change of workload, and unfortunately what happened here was with the renal resource nurse, it was a different person every day. So the dietitian may have stayed the same, but unfortunately we have that barrier of actually getting a different renal resource nurse. How do we overcome that? It's really difficult. We tried the actual, good old printed card in their actual handover, prompting them to actually go back and refer to it. But I think it's like everything. Doing MST screening, it's that constant reminder and constant being a promoter of what we actually do and what's important for the patient. Thanks.
The value of the champion on the ward. Now, speaking of champions, what a great segue. Jamie Feldman. Yes, here we are. Representing the Princess Alexandra Hospital, Jamie is here to present his project on an allied health assistant delegation model to deliver high-protein, high-energy education within an adult tertiary hospital oncology population. Thanks. Jamie.
So here at the PA we have implemented electronic health records called IMR, and we've noted that since their implementation in November 2015 there's been an increase in new inpatient referrals. A possible contributor to this Metro South Health policy is that any patient that is screened on admission as a 2 or greater should be referred to the dietitian. So the aim of this project was to see whether these MST2s could be deferred to an allied health assistant or a dietetic assistant in the first instance, and whether this would be a cost-effective model and would patients be satisfied with it. So looking at the evidence for using an AHA in this way, it's mainly contained within small localised interventional studies, NHMRC level evidence 3.2 to 3.3. I considered the CEPA model when planning this project, and probably the two main domains there would be the outer setting, in which you can see there's clinical task instructions with statewide endorsement, which already clearly define how an allied health assistant can be tasked for this. And then the individuals involved, and in particular dietetic assistant, was very central to the success of this project. So the timeline was that the NUMs of the affected wards would be alerted. There was a 2-week period of pre-implementation data collection, a 3-week period of dietetic assistant training, and then a 2-week period of post-implementation data collection. And the endpoints were the number of patients, the time, and then therefore the cost, and then also the satisfaction. The DA role, as the name suggests, was open to oncology patients only. The patient will be screened as an MST2 by the nursing staff. The dietitian would then receive that on IMR and would either refer them to the dietetic assistant, who would rescreen with an MST, or they would exclude it based on the below criteria. If they were rescreened and rescreened as a 0 or 1, no action would be taken. However, the DA would monitor any change for the MST score for the rest of their admission. An MST of 2, high protein, high energy education would be provided using the NEMO handout, and the dietetic assistant once again monitor the patient for the rest of their admission. If they were a 3 to a 5, they were referred directly back to the dietitian. So as far as our results, we can see here the numbers. Probably the most important thing from this slide is really that we were able to increase the percentage of patients screened with an MST2 that were seen before they discharged. So up from 63% with the dietitians to 100% under this new model of care. As far as cost, is not surprising, the dietetic assistant was actually cheaper per minute. However, it should be noted that the median time was longer for their intervention. However, when you consider the range of times that we collected, there wasn't a significant difference there with, between the two groups. And given it was a new role, it would be hoped that over time the dietetic assistant could get more experience and bring that time down to the expected time that I had of around about 30 minutes. There was no major difference in patient satisfaction between both arms. And as far as the clinician feedback, that was also fairly positive. So the dietitians felt that there was good communication between themselves and the DA. They had a reduced clinical load. It allowed them then to prioritise higher risk patients, while the lower risk patients were seen in a more timely manner. What they felt didn't work so well was restrictions on the referrals to the DA. So they felt it could be bigger than oncology. Could we go into areas like Gen Med? If a patient screen is an MST3 but unsure and yes, whether they could fall under the DA role. The amount of paperwork I feel was due to the data collection, and that could easily be reduced. An important secondary analysis that was undertaken was that there was really poor agreement in MST scores between nursing staff and our clinicians. You can see there 40 to 50% false positive. So the question is really, is it not time better spent by the dietetic assistant to review these patients rather than the dietitian in the first instance? As far as limitations, we had small numbers, but that was representative of the oncology population, where you'd expect them to be more malnourished on presentation to the hospital. The additional FTE is required for this model of care. However, there is an existing dietetic assistant model at PA, which had capacity, so that wasn't such an issue for us. The only other thing would be whether the staff turnover that you would expect in a large tertiary hospital would, affect the reasonable results that we had. And just lastly, the future directions will be to train the next dietetic assistant, whether in fact we can go larger than oncology, and also whether the DA can be trained to provide other education packages, which is actually catered for within the clinical task instructions. Thank you.
Thanks, Jamie. Can I open up to questions? Microphone down here, thanks. I'm sure our VC listeners in the RPOC office will be pleased to see their pathways being utilised here. Jamie.
Thanks, Jamie. My question was earlier on in your presentation, you said that there was a number of exclusion factors, and one of them was patients on a modified texture diet.
Yep.
And I was curious as to why, because still, you can provide high energy, high education, high HPHE education for those patients.
It was really, with the clinical task instruction, it was quite clear about the educational packages that you could use, and one of them was the HPHE sheet. I guess I felt that getting them to talk about then modified texture wasn't really encompassed within that. So just as a first step, but definitely I have done a previous project a couple of years ago which I presented here, in which the dietetic assistant was able to educate on texture modification. So it definitely falls into the realm of the future directions that I have. Yep.
Any other questions? Barbara from the MADA.
Thank you, Jamie. This was very interesting. And I was just wondering whether you had data about energy intake prior to the education to the patient and maybe after a few days of hospital admission, because I think it would be interesting to know whether the education from the DA is different than the education by a dietitian.
Definitely, Barbara. It wasn't part of the scope of this project, but yes, that would be something that could be looked at as an endpoint. If we really take on this model of care and adopt it going forward, that would be something that I'd be interested in finding out.
Thanks.
Great, thanks, Jamie. And our final presentation for today is Jo Roddick from the Royal Brisbane and Women's Hospital. Jo is today presenting on development and implementation of a nurse-led enteral feeding protocol. Welcome, Jo.
Thanks for the opportunity to present today. In 2017, it is estimated that head and neck cancer will account for 3.7% of new cancer cases diagnosed, being the 7th most commonly diagnosed cancer in Australia. Surgery is often the first line of treatment, and many patients require enteral feeding post-operatively. Despite a 20% increase in the number of surgeries across the ear, nose, throat, maxillofacial and plastic surgical caseloads, there has been no change to dietetic FTE. Data collected on the ward I work on, the ENT Maxfax Plastics ward, over a 9-month period, revealed that up to 40% of patients do not receive nutrition support within 24 hours of surgery as per guidelines, due to waiting dietetic review. As a result, patients are not achieving goal feeding rates until 3 to 4 days after surgery. So what are the evidence-based guidelines? As per the Clinical Oncology Society of Australia, there is grade A evidence to support commencement of enteral feeds within 24 hours post-surgery. And as per the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition, there is moderate to high evidence to support the implementation of enteral feed protocols to increase the overall percentage of goal calories provided. A literature search conducted found that the provision of nutrition in the immediate post-operative period improves overall healing. And as demonstrated in the critical care setting, standardised protocols provide a standard to care to guide practice to result in the provision of timely nutrition support. And that allows nursing staff to safely initiate enteral feeding prior to dietetic review. The steps in the action cycle from the knowledge to action framework guided this project. Firstly, I identified a problem and reviewed current knowledge. Audit data was collected over a 9-month period, which highlighted delays to the commencement of enteral feeds post-surgery. A protocol and nutrition care pathway were developed following appraisal of the evidence and literature mentioned above. This knowledge was adapted to context by consulting nursing staff and surgeons during protocol development. And I assessed barriers to implementation through focus groups and one-on-one interactions with key stakeholders. Barriers to implementation included, firstly, belief that the initiation of enteral feeds is not part of the nursing role. I addressed this by recruiting nursing champions to pilot and lead implementation and tailored education to address specific concerns raised in pre-implementation discussions. Other barriers identified included lack of knowledge around which enteral feed to use and lack of clarity around enteral feed starting rates. I addressed this by creating revised enteral feed forms in line with the protocol in the nutrition care pathway and made this easily available on the ward for nursing staff to use. I also put up posters around the ward to increase awareness. The ENT Max Fax Plastic Central Nutrition Pathway provides a detailed and clear path for nursing staff to follow. It involves nursing staff assessing for refeeding risks, as head and neck cancer patients are at high risk of malnutrition prior to treatment due to tumour burden. In doing so, this pathway provides clear instructions on how to commence feeds, which feed to use, and how to calculate goal rate using a goal feed rate guide. This is the enteral feed regimen that nursing staff complete and place in the patient's bed chart. It again clearly states which feed to use, includes its starting rate, and has spaces for nurses to include the patient's weight and calculated goal rate. Monitoring began in August 2017 and will be completed by August 2018 to allow comparison of time to commencing enteral feeds and time to goal rate against baseline data. A survey will be conducted with the multidisciplinary team to determine gaps in knowledge and their awareness of the protocol. Data collected to date shows that 100% of patients placed on the commencement feed protocol have had enteral feeds initiated within 24 hours and have achieved goal rate within an average of 2 days. Anecdotally, I have noticed a reduced pressure on the workload on the ward, and nurses have reported high levels of autonomy, providing me with feedback including, we love being able to start patient feeds as soon as possible. It's a very easy to use protocol, and they love having their own enteral feed protocol. Looking forward, my aim is to develop a work unit guideline, upload the enteral feed form to the intranet for easier access by staff, and explore how to embed the protocol into standard practice to increase sustainability. Thank you.
Okay, so we will open the questions to the VC audience again. Is there anyone, VC audience, who'd like to ask a question? No? Okay, we'll open it up to our audience here. Questions? Yes.
Thanks. It's Michelle from Logan. Thanks for an interesting presentation. I may have missed it, but what do you think was the key to getting the nurses on board with this process?
Well, initially, I just through in-servicing, I guess I came into this sort of looking at ways we could improve the delivery of nutrition care to the patients, and yeah, we're seeing the increase in the load, and then nurses were getting frustrated with having to wait for me when I'd have clinics or other meetings and so forth. So they said, and they just weren't sure of whether they should use the weekend enteral feed regimen or the refeeding forms we had. So they said, what can we use? It's just for us, and sort of went from there.
Any other questions? No? Excellent. Well done. So that concludes the speakers for today. Congratulations to everybody who's presented. I'll get Louise Elvin-Walsh to come down and help me at this stage because I'd actually like all of the participants to come back up and stand up here for a photo opportunity and to receive your certificate of participation. Let me bring this. Awesome. So I have, while all the presenters are coming up, don't be shy, you've already come up before. We know who you are, and it is a good way for people to remind themselves who you are when they're thinking about who to vote. So this SurveyMonkey How to Vote is on your run sheet. You can either scan it or type it in and vote. And I have accidentally, on purpose, put our evaluation questions after the vote, so your vote won't count until you answer our evaluation questions. Thank you. Now, all of our participants, Louise Elvin Walsh is handing out a certificate of participation, and to go along with that is some wonderful support from the Translational Research Institute. And thank you to Carla Patterson, who's facilitated this for us. But each participant gets a $100 cash voucher for simply participating in the event this year. So well done, congratulations. And thank you to TRI for their support. All right, so just get some photos moving in. So while the photos are happening, people on video conference logins also can vote. So you are welcome to add your vote for the most popular. So the People's Choice Award really is what your favourite one was. It doesn't have to be what you think was had the most scientific rigour or had the greatest evidence. It really was just your favourite that will be chosen by the audience. Great, thanks everybody. Afternoon tea is about to be served, so please finish your voting before you leave for afternoon tea, because once everyone has left, we'll assume all votes are in. Afternoon tea will be served outside in the courtyard, and that will be delivered, I think, in the next couple of minutes. If it's not there, it's on its way. So make your way out to the courtyard. Our volunteers will be able to show you which direction to go. We will get you to return back after afternoon tea. The judges will be doing their hard work now and deliberating on the winners of the different categories of awards. And so you will hear who has been the winners of the awards